discussion on expanding access and innovation in care delivery using technology. Now joining us, Farid Vij, co-founder and CEO, Citizen Health, Chris Altchek, co-founder and CEO, Cadence, Sean Duffy, co-founder and CEO, Omada Health, and moderator Sebastian Caliri, partner, 8VC.
I think you're probably that one. The other side. Started by missing the entrance, and then.
All right. Dr. Oz brought up a very good point about curiosity. He talked about curiosity about a question as a prerequisite to answering that question. And so I'm going to ask us all to think about a question to get this discussion started. I want you to start by thinking about a trip to the doctor that you've had sometime in the past year, past 18 months. What was that like? Now think about, imagine what it would be like to visit the doctor in the year 1990. And my question is, what is the biggest difference? The exam rooms look different. The doctor asks you different questions. The population prevalence of obesity in 1990 was something like 15%. The population prevalence of obesity in 2025 was 37%. I would argue not much has changed except for the people in the waiting room who in 2025 are much heavier and much sicker than they were in 1990. I think this is a pretty remarkable thing that in spite of the growing prevalence of chronic disease, not much about the way we practice medicine has really changed. It's remarkable also, given what's been going on in technology, that not much has changed. I'll actually, we have a pop quiz opportunity here. What year did AI first pass USMLE Step 1? This is the exam that doctors need to take to become practicing physicians.
2023?
We get a 2023. That's pretty good. It's close. But it was actually in December of 2022 that MedPalm actually, from Google, first passed the USMLE. This is to say that we've created basically free medical intelligence in the technology world that also still hasn't made its way into the way we practice medicine. So, I'm joined today by Sean from Omada, Chris from Cadence, and Farid from Citizen. All of these guys are using technology to change the way that care is delivered. And the focus of this conversation is going to be on what that looks like, what is its impact, and what's the outlook, where are we going from here. Let's start, Sean, with Omada. Omada is really a tech-enabled pioneer. One of the first players on the stage. Is now a publicly traded company. When you got Omada started, what did you see in how we treat chronic disease, and how did you re-envision that?
Sure. Well, thank you, Sebastian. Hi, everybody. I'm Sean Duffy, co-founder and CEO of Omada. I'm not your transportation secretary. There is another. My email inbox is flooded each day with complaints, so keep them coming. Kidding aside, Sebastian, I think you hit on something very important in that we're handcuffed with this model of a visit. And I founded Omada Health while in medical school and got very interested in metabolic disease and obesity-related chronic disease, given just this tsunami that was coming for the country, even back then. And then you'd sit in the homes of people with diabetes, and the medical academic would say, well, they're under care. They have a primary care doc. They have been prescribed a medicine. They have been told what to do. Yet they weren't getting any better. And it was obvious that the care model needed to switch from visit-based care to between visit-based care. And so that's what Omada sought to do, and spent over a decade working toward that new care model with proactivity between visits for our members and connected hardware and goal orientation relative to listening to what these patients want toward to their success. And I think that's I think that's important, and it's really a reflection that our system is not well set up to handle chronic disease.
So, we were talking a couple of weeks ago, and you mentioned the scale of the impact you had, the number of patients that you're serving, and I found it to be pretty amazing. Why don't you talk a little bit about the scale of Omada today? Yeah,
it's been quite a ride. I mean, we've enrolled well over 1 million patients, now actively managed as of the end of Q3 over 850,000. But equally, we don't think we've done what we need to do. Our explicit mission at Omada is to bend the curve of disease. And that's going to require us to keep our ambitions incredibly high, raise our sights. I think it's doable. I think it's doable especially with the context of GLP-1s. whereas these medicines in concert with lifestyle can have enormous both physical and psychological impacts with patients. So we got to keep running hard.
Yeah, so it's this innovative stuff, although the experience for most patients, the healthcare system hasn't changed, this is not really a drop in the bucket anymore. A lot of this is proliferating throughout the system. Chris, you also looked at how we manage a lot of chronic disease and re-envisioned it. Why don't you talk a little bit about the Cadence model and some of the results you've seen?
Yeah, so at Cadence, we are trying to keep seniors healthy and at home using technology. What does that look like? We're now actively monitoring blood pressure, heart rate, weight, blood sugar on over 70,000 seniors from their homes on a daily basis. What that means is when a patient's blood pressure starts trending in the wrong direction, that our software alerts our clinical team, and the clinical team is usually in touch with that patient or their family within minutes. That could be pending a heart failure exacerbation or an infection. That kind of data is allowing us to get upstream from these big issues. Give you a patient example. We had a patient in rural Oklahoma a couple months ago who triggered a blood pressure of 190 on Saturday night at 11 p.m. The patient was trying to figure out should they go to the emergency room or not. We were in touch with that patient within minutes after the software platform alerted us, speaking in that case to the patient's family. With our team, had the patient take another blood pressure medication, recheck their blood pressure an hour later, see if it came down and stabilized. In that case, it did stabilize, and so the patient was able to avoid a Saturday night ED visit in rural Oklahoma, which obviously is very meaningful. And more importantly, the patient is able to get peace of mind knowing that somebody's taking care of them. And so all of that data now is peer-reviewed and published, and we're seeing a 27% reduction in patients going to the hospital compared to the compare group. So this is very high potential. And when you look at it from the American taxpayer's perspective, most of these patients are Medicare patients where the government is paying for their insurance, and it's saving the US government today $2 million a week. And that's only at 70,000 patients. So there's a big opportunity here.
Chris, sometimes people will hear anecdotes like that where, on the one hand, they're excited about how, hey, we moved from an episodic model to this continuous model, saved a patient's life. That's all well and good, but on the other hand, is this disintermediating the physician? Is this affecting the patient-provider relationship? How do physicians see tools like this? How do you include physicians in this model?
Yeah, so physicians, and especially primary care physicians, understand that we're in a historic shortage of primary care physicians across the country. And so the question is, how do you make them more effective? And at Cadence, we don't think success is a 5 to 10% improvement in effectiveness. We think success is a 5 to 10x improvement in evidence-based, outcomes-driven interventions, and that's how we're measuring success from a physician standpoint. And I think there's wide buy-in. We're now in 35 states with academic medical centers and rural and local community health systems, really trying to future-proof our primary care infrastructure so that we can tackle chronic disease in a way that just hasn't been possible before for our most vulnerable seniors.
Now, Fareed, at Citizen, you guys are looking after patients with rare disease. Why don't you first explain a little bit about how we define rare disease, what this looks like, what the experience is for patients and caregivers. I think what you're doing is a little bit different from what Sean and Chris are doing. It's like, not only are your patients, not really able to access care, there's limitations in what services are available, but really there aren't good options at all. It's not just there's an opportunity for improvement, but there's not much out there. Why don't you talk a little bit about these rare disease patients?
Yeah, absolutely. So one, thank you for having me, and it's great to be here. So at Citizen, we focus on rare disease, and look, today we define rare disease here in the country as any disease where there's 200,000 patients or fewer that have that diagnosis. Now, what does that actually mean? We've got about 330 million people in this country. We estimate a little bit over 30 million have a rare disease. I always joke and say rare disease has a bit of a branding problem because more than half of those 30 million are children. They're pediatric conditions. 80% of those are caused by a single genetic mutation. That means one mutation in your DNA that is causing the entire disease. So 1 in 5 children ends up with a rare disease. 95% of them don't have a single approved therapy. The average rare disease takes 7 years to diagnose. So you can imagine the cost of care and how many tests, how many doctors, et cetera. And because there's no standard of care, because these diseases are so understudied, parents and families are effectively doing guesswork. The average patient on our platform, we work directly with patients and families on one side of the platform. We power them with all of their health information so they can navigate this journey in a much more effective way. But the average patient on our platform is seeing 9 providers concurrently. They're seeing a PCP, a neurologist, a occupational therapist, a physical therapist, et cetera. And their care isn't just inside the 4 walls of a given institution, it is 24/7. It's at school, it's at home. For a lot of these children, if the parents can afford it, which is largely not the case, one parent can't even work full time. So look, one of the biggest statistics that has always stuck in my mind, and to your point, has not changed in decades, we have a $4 trillion spend in this country. The sickest 1% account for 25% of that spend. The sickest 5% account for 50% of that spend. So you have 16.5 million people accounting for $2 trillion. That's where we're focused, and that's where a lot of rare disease is.
So you're describing a population that's ping-ponging between different providers. There aren't usually approved therapies for these patients. There's no real standard of care, and they're trying to piece together bits of information to make good decisions. Usually these are pediatric populations. Usually these are kids. They're high cost for our insurance programs. How do you re-envision this whole experience and how care is delivered for patients with rare disease? What does the AI advocate look like?
No, absolutely. So you mentioned the AI advocate, and that's our primary product. And what we're doing is if you are sick, data has shown that the #1 thing that will actually help you with longevity, with fewer emergency room visits, is if you have an advocate by your side. Now, that's usually a caregiver, mom, dad, brother, sister, friend. They know everything about you. They're constantly looking out for you. They have an irrational reason to not take no for an answer. So they're looking for what is the right specialist, what is the right diagnostic, et cetera. We believe that we can take AI and put one of those in every patient's pocket so that you can be better prepared for appointments. You can spot early interventions and diagnostics. The #1 thing that improves the care of these patients and generates a better outcome is early intervention. So if you imagine a world where every single patient has an AI friend that knows everything about them, that is permissioned by them, can talk to everybody else's AI friend so that you can start to understand what has worked for other patients like me. We're not trying to play doctor, but empower that family and patient as well as their care providers to be able to make the best decision. You can completely change not just the cost curve for these populations, but really the fundamental day-to-day, both for the patient as well as for the family.
Yeah, so in Citizen, you're using AI to enable patients to better navigate their own health and make decisions for themselves in a world where there really isn't a lot of detailed medical literature and guidelines available. You know, Omada and Cadence were both started before this whole AI wave. And so let's start with Sean, but what has AI meant for your business?
I mean, it's been a blast. We joke for Omada, it's the year of the Gs, GLPs and GPTs. Because I remember with my co-founder, we're in San Francisco, we're at Dolores Park, and we're imagining what the future of a product could look like. And some of the things that we talked about then, we only thought, well, could software one day get us there? And it's happening, and it's accessible, and it's easy to deploy. So it's been an absolute blast. I mean, we have a number of AI tools directly for our members, AI tools for our care teams. You know, equally, we believe that the intersection between real, like, human accountability and compassion, you know, and the technology can, you know, influence the most positive health outcomes. So it's been a fun ride.
Yeah, on the Cadence side, the AI strategy is one singular focus. It's how do we move from reactive monitoring to proactive intervention. And so 3 examples where this has really started to play into the day-to-day is before AI, it was taking us 45 minutes to build these personalized chronic disease care plans for each patient. And now the AI platform will ingest hundreds, and for some of these patients, you know, our average patient is 74 years old, it's thousands of medical records and generate the personalized care plan out of that. We actually had a patient in Alabama about a month ago who before they were on Cadence, they were complaining about constantly fainting for the last year. The PCP couldn't figure it out, the specialist couldn't figure it out, and we ingested, for this patient, 700 medical records and figured out that actually there was 2 medications that were interacting adversely, and we were able to coordinate with the PCP, and in this case, the psychiatrist, to figure out what the issue was, what meds should be discontinued, and now the patient has their independence back. That would have been very hard to accomplish without AI. So that's one example. Second example is on the alert side, where the goal here is how do we use the data we're getting. We're getting about 2 million vitals a month right now from patients. How do we use that data to get ahead of strokes, heart attacks, infections, and get further upstream so we know these things are brewing before the patient even knows they're brewing? And we had an example just last weekend where the patient, we were looking at heart rate data and blood pressure data that wasn't hitting an absolute high or low for either, but the trend between both signaled there was an issue. Triaged the patient to the local PCP. They were having what's called a mini stroke, and the patient was able to coordinate with neurology, the primary care doctor, get their meds titrated, and ultimately still today is living at home and independent. And for all of us who've dealt with family members who have had strokes, we know that that's the best, that's a very big deal, a very big outcome. So that's the kind of work where it wasn't possible pre-AI, and especially for our parents and our grandparents who are at very high risk, we're starting to see big rewards. It's about 20,000 alerts we're managing right now on a monthly basis, with 1,000 of them ending up in meaningful clinical intervention. And so that's just the beginning. I think we can make that much more meaningful.
Absolutely. Fareed, these models keep on getting better every year. What about Citizen? What lies ahead for what you're doing?
So, we talk a lot about continuous care. We've talked about that a few times. I think that's probably the most powerful thing about what these models are allowing us to do. So oftentimes what we find is, in the past, we would have built some software, a digital solution for a patient or family, but they have to know what question to ask, what button to press, what to do. The ability now for AI to actually be proactive, I think, Chris, what you talked about in terms of alerts, proactive alerts, I think it is fundamentally the technology that will allow us to get from episodic care to continuous care. For our populations, like I said, a lot of their care happens at school. So one of the most important things these families have to do is, my guess is most people have not heard of an IEP, an individualized education plan, where every year, twice a year, and usually continuously, you are negotiating with your school on, do we have the right nurse there? Do we have the right services? My kid has dozens of seizures a day. Is someone going to make sure that they get the right anti-seizure medication on time? Those are the types of things that a parent and family doesn't necessarily know how to navigate. One of the things we see on our platform is patients are constantly using the AI advocate to upload their IEP and say, tell me what we should do. And it actually gives them the right guidance, because it can also look at thousands of other patients who have the right IEP and what their outcomes have been. The same can apply for when they're not getting access to the right service, but they're really eligible, but they don't know how to access that service, how to be able to appeal if it's an insurance scenario. That's the type of stuff that AI can proactively do and do the work for you, rather than just be a tool for you to use.
So we've got examples of how technology redefining care can, in some cases, save lives, make people healthier. In some cases, save caregivers a lot of time and a lot of frustration. At the end of the day, a lot of this stuff is delivering real health outcomes. And I think we ought to ask, come back to the question I posed at the beginning of the discussion, which is, why hasn't the experience of the average American seeking care from a doctor changed very much? And I think that although we have our success stories here and our models here, there are real policy blockers in certain cases to proliferating these and getting them out to more patients across the country. One of those issues that I want to pivot to now is insurance reimbursement. Most of the healthcare dollars in this country come from insurance. It's like about 85% of our $5 trillion in spend. And in order to bill insurance, you need a CPT code. This is a set of 10,000, 11,000 codes that's defined by the American Medical Association, these codes. And without one, you can't actually bill insurance for any of your services. And it turns out that when you're innovating, like all of these founders are, you design a new care model, you might not match up to a CPT code. You might not be able to bill insurance. And I think that this ends up being a big problem when we think about getting more tech-enabled care out into the country. So question, Fareed, you've described all of these great things for rare disease. Can you get paid by insurance for any of it?
No. Today that doesn't exist. Now, most of the cost of care, and by the way, I've spent a lot of time on pediatrics because that's where so much of rare disease is, but obviously it extends to adult care as well. Most of this care accrues to Medicaid. They're the ones that are, that is who is picking up the cost for all of these services, for when there is not an early intervention, for all the ED visits that end up happening as a result of that. And I think there's two areas around this. We already have programs in place where if you're saving caregivers and families a tremendous amount of time, there are waivers for that. There is already very clear evidence that by being able to, I use the IEP example, get the right IEP so you're getting the right services at school results in fewer, not just emergency room visits, but also other interventions that you might otherwise go through. All of that ends up reducing costs. So there's a very, very clear place for, we believe, a tool like this to have reimbursement. I think the other thing which is a bit adjacent, but I'm just going to touch on quickly. I talked about 95% of these, 95% of these conditions don't have a single therapy that's approved. If you look at all of the science and technology that we're excited about around gene editing and CRISPR, there was a lot of, it was very public what happened with baby KJ and the amazing story there. That's almost tailor-made for rare disease. And so there's also things inside of how we build drugs and how we approve therapies. And I think there's tremendous work being done inside of the FDA today in creating those accelerated pathways that would also reduce that cost to Medicaid. So those things are very closely tied together, and I think there's opportunities on policy to move both of those forward around rare disease.
Yeah, if we have time, we'll come back to the FDA piece, but I think one takeaway is this stuff is obviously valuable, but very, very hard to get paid by insurance. What's been your experience, Sean?
The reimbursement system of the US is built for paying for synchronous time, and it doesn't pay for proactive longitudinal care models. I mean, we actually worked with the AMA. We got what was the first ever digital specific CPT code approved, the Cat3 code, that simply served as billing infrastructure so we could bill a value-based reimbursement model on fee-for-service rails. But there's a lot of legacy, and I think it's great to be part of forums like this, have conversations here, because that doesn't need to be the case. There can be different ways of paying for services and technologies that are more oriented toward outcomes.
Chris, you started Cadence with some CPT codes that sort of match up to the services that you deliver, but I think it's fair to say that your pathway to insurance reimbursement still hasn't been especially easy. So what are some of the other challenges that you end up facing?
Yeah, so a couple things. We started, the first Trump administration introduced the remote monitoring programs for chronic disease, which was really visionary in 2019. And so we were able to utilize those CPT codes. One of the big challenges is that Medicare pays different rates in different geographies, which maybe makes sense for clinical services, but doesn't make sense for technology where the costs are the same. And so what that means in practice is these services are paid 30% less in rural Tennessee versus Seattle, Washington, even though access to care and chronic disease prevalence is dramatically higher in rural Tennessee. So we need to figure out, as a country and as policymakers, how do we pay for technology so that nobody, especially the people who need this the most, are not left behind in all of this wave of innovation. And obviously where Medicare goes, so goes the US healthcare system. And so these are incredibly important policies. I'd say that's number one. And then number two is we need to align incentives, evidence, and innovation. And around chronic disease, there are challenges where the biggest Medicare Advantage payer in the country, United Healthcare, is stopping reimbursement for diabetes and hypertension, which is contrary to what we're all trying to accomplish here. And so making sure that the big players are aligned here is really, really important if we're going to take advantage of this massive wave of innovation that's happening right now in the US to tackle chronic disease.
Yeah, I think you brought up a really important point that Chris Klomp mentioned earlier, which is in many cases, particularly around reimbursement changes, CMS leads the way. CMS is the most innovative player. And so I think there's a huge role for government when we think about, hey, can we create new ways to pay for this type of transformation? CMS has the most important role to play here. We're getting close to the end of time, so let's wrap with a final question to each of you. You've each in your own ways worked to make the country healthier by transforming care with technology. Are you optimistic, pessimistic, and why?
I mean, super optimistic. There's so many things I'm excited about. I will say recently, just GLPs plus programs on side is magical. I mean, GLPs can be behavioral catalysts. It can open, positive psychology toward being willing to make some changes in your life that you otherwise, wouldn't have, and we see that on a daily basis. I think that's incredibly inspiring.
I'm optimistic because for the first time, CMS, CMMI, the Rural Health Transformation Fund are all working on root cause, let's build a better healthcare delivery system in the US, and I think we can make more progress in the next 24 months than we've made in the last 24 years when it comes to chronic disease management. I'll end with one story. A patient in Alabama with hypertension, diabetes, who was super fatigued. We started working on her diet, exercise, lifestyle, looking at her data on a daily basis to make her accountable, make her sort of invested in her care, and she started to feel better. And what she said was, I didn't realize how bad I felt until I started feeling good again. And I think that's kind of the message here is, let's make US healthcare less about hospitals, more about keeping patients healthy at home and helping people feel good again. I think we can do it. I think we can do it in the next 2 years if we're focused.
I'm very optimistic about it. I think across the board, inside of CMS right now, we have initiatives that are helping patients get access to their data so that we can make this much more proactive. We have models in CMMI that are changing what the incentive is for pharmaceutical companies so that you are actually building cost-effective drugs for these rare disease populations. And I think there's tremendous progress in the FDA right now in terms of, look, at the end of the day, if you believe in personalized care or precision medicine, which is that each of us should be treated based on us as an individual and not some broader population, everything is a rare disease. There's only one of you and there's only one of me. And I think that the FDA is doing really interesting work in creating pathways for some of these NF1 treatments, for some of these ultra-rare conditions, some of the work that we do. That's really going to blaze the trail for how we're going to develop therapies and how we're going to sort of move forward across the board.
And it's a great note to end on. I think all of us on this panel are really grateful for the work that's been done at CMS and the FDA over the past 8-9 months. And on the other hand, there's work still to be done to enable us to transform more of our healthcare delivery system with technology. So thank you, guys.
Thank you.
Thank you.